to catch what they missed. So why don't we go ahead and get started? Our featured speaker today is Jaime Seltzer, MEAction's scientific director and a Time magazine's 100 most influential people for health. As the scientific director at MEAction, which is a healthcare nonprofit organization that focuses on infection-associated chronic illnesses, she's responsible for project management for clinical and research-associated projects and fostering communication between research scientists, clinicians, and people with infection-associated chronic illness. Today, Jaime will share science-based actionable tips that patients and caregivers can use to improve daily life and manage symptoms, such as practical advice on pacing, self-care, and accessing resources. So let me stop sharing and you can take it away.
Hi, everybody. Thanks for being here. Nice to see everybody. I'm just going to go over some tips for caring for people with MECFS, including a little bit about dealing with your healthcare providers. And I'm going to talk a little bit about some useful resources. I recommend having your phone out to take a shot if you want to, or using the print screen button on your computer. While this will be available in the future, there are some things you may want to look up now, and the presentation includes some QR codes that you can scan. So let's get going. So we're going to introduce MECFS and the relationship to ICCs. We're not going to take up too much time on that because I think that a lot of us will be familiar with that. We're going to talk about treatment strategies for 20 minutes. Hopefully we'll have that much time. Strategies for engaging with healthcare providers and resources in conclusion. Remember to mute your mic. Consider writing your questions down or putting them in the chat to be answered later. So that you don't lose track of what your thoughts are over the course of the presentation. So we already know, if you're on this call, MECFS is considered an infection-associated chronic illness. It's coded as a neurological disease, but it has prominent symptoms in multiple body systems, including neurological and immune systems, but also there's some pretty good signs of impaired cellular metabolism, which may or may not be due to immune effects. It does run in families. There's a genetic susceptibility, but typically with an infectious trigger, I say typically because it's not always an infection. Sometimes another immune modulated trigger can be present. Before the pandemic, there was a 0.42% prevalence in adults, but it's many times more common than that now. We consider it in the context of IACCs. Other examples of infection-associated illnesses are POTS, MCAS, Ehlers-Danlos, PANS, and children, which is a neuropsychiatric syndrome, often but not always after strep throat. And it's typical for these to occur in combination, which from a treatment perspective really matters. There's a notable overlap with orthostatic intolerance, including POTS in particular. A lot of people ask me if Ehlers-Danlos is a heritable syndrome, why do we put it here? Oftentimes when I talk about these illnesses, I say that the disease is triggered or unmasked by an immunological trigger or an infection. So while people are born with a collagen disorder, it may be unnoticeable or certainly not anything that you would consider a pathology until the trigger hits, and then you see much more severe symptoms thereafter. The more interesting thing to me is that this is a pattern we see in neurological illness in general, that most of the things that we think of as more mainstream neurological diseases, more well-known neurological diseases, are triggered by infection also, including Guillain-Barré, various kinds of encephalitis, myasthenia gravis. A lot of these are pretty familiar. And of course, the number of cases of MECFS has exploded in the wake of COVID. Multiple studies report that about half of long COVID cases at 6 months meet stringent definitions for MECFS. And a recent study, quite recent, this just came out a few weeks ago, found that people post SARS-CoV-2 infection had a 4.5% prevalence of MECFS at 6 months, as compared to 0.6% of those who had tested negative for infection. Note the way I'm putting this, not didn't have COVID, the people who never had a positive test versus the people who did have a positive test. So presumably there's actually a lot of overlap in these two categories in reality because testing is not 100% accurate. However, this certainly shows that MECFS is strongly associated with infection in some cases. In previous studies, up to 80% of cases of MECFS were associated with an infection. Again, that's still 20% that were not. Some good studies on EBV, some good studies on enteroviruses, other coronaviruses outside of SARS-CoV-2 as well, have been shown to trigger MECFS or an MECFS-like disorder. But punctuated onset with a lot of different triggers is a lot more common than I think is commonly discussed. If you talk to people and you hear their stories in detail, there are often a string of never better since health events, with a final straw event that leads to more severe symptoms. Other stressors apart from infection, like we said, including surgery, trauma, vaccination in some cases, right, we've heard, and even the immune changes during pregnancy have been shown to be a trigger for MECFS also. So I like to kind of zoom out on what is the pathology of MECFS, or what is it that we're actually looking at, because especially when I talk to clinicians, they're often overwhelmed by the number of symptoms and they don't really have a way to conceptualize the disease as a whole. So this is the way I conceptualize it. This is my personal opinion. It's initiated by an immunological stressor, and much of its pathology and many of its symptoms can be conceived of as an adaptive host response to either ongoing pathogenic threat or to long-term inflammation. These adaptive responses might be better framed as compensations to protect a system under assault, rather than necessarily individual errors that need to be repaired. So in my conception, sorry, it's already been a long day, guys. The symptoms are due to ongoing immune, metabolic, and endocrine shifts that take place in order to shield the host from ongoing damage or to compensate for such protective processes, along with the damage caused by the initial infection or provocation and any reactivating infections or co-infections. I think we're pretty familiar with this. This is the diagnostic criteria often used in the US, so we'll scoot forward. This is a diagram from the Mayo Clinic Proceedings article where we discussed MECFS. I was a co-author on this paper that was Dr. Stephanie Grach was the primary author. And what I like about this image is that it shows that despite the IOM criteria only requiring a limited number of symptoms, actually we experience many different symptoms as part of this disease in multiple body systems. We also have a way of conceptualizing severity in this disease that I think can be useful for people who are unfamiliar with the disease. I think that most people don't have a very good picture of how severe it can be. People in the very severe end are bedbound and unable to carry out most activities of daily living, often extremely sensory sensitive, and may need total care. If you haven't seen this diagram before, this compares the quality of life in MECFS to that of other diseases. You'll notice it's at the top left, and it is the lowest out of all the diseases being measured. One of the things I point out in this diagram is how much lower the mean is than the median. And what that means is that people with severe MECFS have extraordinarily low quality of life, and that's dragging the mean down in a way that doesn't affect the median so much. This is from that same paper that I co-authored that discusses how PEM presents according to patients. We used patient descriptions in each of these categories. And really emphasize that PM is not being more tired than usual. It's not deconditioning. It's not second day muscle soreness. It's not necessarily relieved by sleep. But we also described in different body systems how it presents. Important to recognize the common comorbidities with this disease because it's going to affect how we can treat. And now we're up to how to do that. So once again, I like to zoom out and look at the big picture first, because otherwise it can get a little overwhelming. With medications, we want to start with the symptoms that affect us the most. We want to use the edict of start low and go slow, and recognize that an effective dose in ME is not the same thing as an effective dose in people with other diseases or healthy people. You want to also start with the meds that are useful for most or many. Try those first before attempting to address a specific symptom. I consider LDN and pyridostigmine, also called Mestinon, to be two of the most universally applicable medications. The ones I hear from patients again and again that it helped them, that it didn't cause worsened symptoms, provided the dose and the frequency are correct. And include over-the-counter interventions that are useful for most many, like ubiquinone, lactoferrin, B vitamins, vitamin D, and omega-3 fatty acids. Lifestyle interventions, of course, symptom contingent pacing, careful diet, compression, fluid salt, memory aids, and other cognitive aids. And also things to work on limiting sensory overload. So earphones and dark glasses and things like that as needed. And in terms of therapy, I think acceptance and commitment therapy can be useful. I think you really do need people with experience in chronic illness to deliver that therapy. And focusing on hopeful realism rather than focusing on someday all these problems will go away. Very useful. And what I tell doctors is do not write checks pathology will not cash. If you have 1 out of 20 patients actually recovering from this, don't tell your patient everyone will get better. It might cause temporary improvement in mood and outlook, but long-term it has worse effects because people need to be able to plan for their real life and their real futures. So it's very important to be honest and earnest. We'll talk more about each of these categories, so I'm not going to linger too long on this slide. So if we're going to talk about addressing different dimensions of health in someone with MECFS, I consider each of these boxes to have a different set of interventions that are helpful. For comorbid diseases like POTS, you can address them very particularly with medications for POTS. Same thing goes for MCAS. But you still have to deal with the damage from the original infection. If you had COVID, you might have lung fibrosis or liver or kidney failure. All of those things still need to be addressed, regardless of the ongoing, more syndromic symptoms and issues. If there's viral persistence, viral reservoirs, viral reactivation like there is with EBV, or if there are co-infections due to a compromised immune system, they have to be treated with antimicrobials, antivirals, antibiotics, and so on. Sometimes SIBO treatments, depending. And that's small intestinal bacterial overgrowth, if you guys are not familiar, where you produce more bacteria than you should be in your gut, and motility is slowed, so it kind of replicates and causes problems. And then you have those metabolic, endocrine, immunological shifts that are characteristic of these syndromic diseases like MECFS. And we have few but important medications that can kind of affect that axis as well. This is from Dr. Curtin with her permission. this is just a list of different interventions that you can use for comorbidities that are common with this disease. I will say that I'm very hesitant with fludrocortisone and other corticoid-like compounds, the same way I would be very cautious with SSRIs and SNRIs. Some patients respond really poorly to them. Um, if people have particular questions, we can talk about that. So from the acute infection, it's important to distinguish post-ICU syndrome, which could be quite different. But there are some issues of damage from acute infection that might be specific to your original infection. And of course, if you have viral persistence, it might be important to know the original infection too. And again, you don't have to have been triggered by an infection for this to still be an issue, because co-infections are seen in people with immune compromise. And I like to say functional immunocompromise so that people understand that we're talking about people who are up and walking around often, um, and are not necessarily at the same stage as somebody with, say, no detectable IgA. But at the same time, it's obviously affecting the health of the person, because they are much more susceptible to infection, and infection is harder to get rid of once it's set in. I think most people here understand symptom contingent pacing, but it's very challenging to implement. And of course, the more severe presenting the patient is, the more careful someone has to be, and the less likely that mainstream advice on pacing is going to necessarily be helpful. I've talked to people with severe ME about pacing, and they agree that they pace, but it looks very different to what somebody with minor and or moderate presenting ME might employ. You can use wearable devices, and if you do crash, take note of what your wearable devices were telling you the day before and try to keep below that level. Some wearable devices can be programmed to warn you when you're approaching a preset limit. And if you haven't yet seen the pacing and management guides, you can go ahead and scan in the lower left-hand corner. The adult version is the version that was first, and you might be most familiar with. The pediatric version, if you have a child at home with MECFS or another energy limiting illness, that incorporates some accommodations for school, and some other advice that pertains to children and teens, and that was developed in conjunction with long COVID families. And the one for clinicians was developed in conjunction with the Patient-Led Research Collaborative, and it includes citations so that if you have clinicians who are very evidence-oriented, they're going to be able to look up all of the citations around pacing and why it's important for people like us. Okay, so now we get into a bit more of the nitty-gritty. And this is something that I think, this is a lot of information I think people don't hear as often. From my point of view, it's important to incorporate no more than one medication at a time. It's very challenging otherwise to see which medication was effective, and if you had an adverse response, which medication caused that adverse response. I know a lot of patients who are really excited because their clinician has given them 2 or 3 things to try. They take them all at once, they have a negative response, they don't know which medication it was. It can be very challenging to make yourself try each one individually, knowing that one of them had a bad response and could lead to PEM. I think that clinicians are so used to dealing with acute conditions that they don't conceptualize what they're necessarily giving as a forever med. They still have this idea that everything is not just curable, but will eventually go away. And so oftentimes they will give medications that are really more for acute situations forever. So we want to try and choose the most effective medication that has the smallest likelihood of long-term side effects. And at the dose that works, the lowest dose that works. In terms of herbal and over-the-counter interventions like supplements, We want to keep in mind that just because they're natural doesn't mean that they don't have any potential side effects, so this still applies to them. If and when you're trying something new, try and keep a symptom diary as you begin to take the new med and record your well-being each day on a scale of 1 to 10. If you know that there's a particular symptom that you believe it should affect, keeping track of that symptom in particular on a scale of 1 to 10 can be useful too. Um, as long as it's safe and as long as you discuss this with your healthcare provider, it can also be useful to go off and on the same medication a handful of times. You don't want to do this with things like SSRIs or SNRIs, for example, which is why I say discuss with your healthcare provider first. But if it's a medication that is safe to go off and on, you can be sure that it's actually affecting your symptoms. Sometimes we have good days and bad days, and they are not directly related to the medication that we're taking. We want to be sure. Also pay attention to whether your medication is water soluble. That would include things like vitamin B12 and folate and the other B vitamins or amino acids. Pyridostigmine is another example of a water soluble medication, or whether they're fat soluble. And the reason that you want to pay attention to this in terms of figuring out if your dosing is right is that fat soluble medications and vitamins will take longer before they're absorbed and before you notice a change. And the same thing goes for going off of them. It will take several days before you notice whether the effect has worn off or not. Whereas water soluble, you should notice within minutes the effect that that might have. So, oh, looks like I doubled the first half of this. So the other thing about water soluble medications is that they have the strongest effect when they're taken first thing in the morning on an empty stomach without fats. Water soluble stuff is soluble in water, so you don't want to add things that it's not soluble with. And you can keep this in mind when you need to increase their effects. So, this for this to be as effective as it can be, I should take it first thing in the morning with water only. Or let's say you think that the effect is a little too strong. Well, then you can purposely take it with food. Fat soluble medications, on the other hand, will have the strongest effects when they're taken with a meal that has fat in it. Or better yet, a fatty beverage that's really easy to digest, like hot chocolate. Keep this in mind if you need to increase or decrease their effects. So some examples of fat-soluble medications or interventions, vitamins E, D, and A are all fat-soluble. Basically anything that has an "one" ending is a ketone, it's fat-soluble. And vitamins B, C, amino acids, anything with an OL ending has an alcohol group. That means it's more likely to be water-soluble. So don't rule out dietary interventions. They are commonly prescribed for neurological disease. And just because a dietary intervention is something you're considering doesn't make your disease less serious. Carbohydrates should also be considered in light of their role in blood pressure and blood volume changes. If you eat a lot of carbs, your blood volume will increase, but because your blood sugar will go up, but also that will make your heart rate go up. So a lot of people who have a diagnosis of POTS might stick to more mostly protein, mostly fats, or at the very least, they're making sure that when they have a meal, they have some fat and protein in the meal and they don't eat a meal that's pure carbohydrates. Diets that lean more towards paleo or even keto could be considered very carefully, very thoughtfully. And in some cases, it may depend on whether the patient is in early disease when there's more inflammation. A diet like that might be more advisable. There's not a lot of studies on this, I should say. In fact, there's only one study that looks reputable for different diets in MECFS, and it is a series of case studies for a ketogenic diet. And the results were positive, but so it's 3 case studies. So you have to take it with a grain of salt. And also, I found this interesting. This is again my personal opinion, but I've heard a lot of patients say it. The best food for you may depend on whether you're in a state of active PEM or not. Because during immune activation, your T cells might be very hungry. They mostly are very sugar hungry. So during PEM, people might feel the need for sugar with some fat, like ice cream or something along those lines. Whereas the rest of the time, lower sugar is better. Um, Foods that are challenging to digest might need to be cut very fine and cooked through. So this is one of the things that I encounter over and over again. If you're sent to a nutritionist, or even if your doctor is just talking to you about good nutrition, they're going to give you some very mainstream advice that is not necessarily useful for you. They're going to tell you eat lots of fiber, eat more vegetables, just exercise after you eat to make sure that you get your metabolism revved. And a lot of this is not good advice for people with ME. Um, if you want to get vegetables into somebody with ME, putting them into a grinder before cooking them can be very useful. So this is directly taken mostly from the Mayo Clinic Proceedings paper, and it's just some suggestions for different interventions by symptom. I'm not going to necessarily read those aloud. I will just stay for a minute or two on each slide so that you guys can take a look. I will add, however, that the higher dose and lower frequency for pyridostigmine is another dosing error I see a lot. If you actually look up the half-life of the pyridostigmine that is not slow release, you'll see it's actually pretty quick. So if you have somebody giving a low dose first thing in the morning and then a low dose the next morning, it has had the time to surge, completely wear off, and you're starting from scratch again. Um, Definitely tell your doctor to look up the half-life of the drug if they're not used to low dose. Once again, just recommendations based off of symptoms. I will give everybody a moment to take a look rather than reading aloud. I will say that for cognitive dysfunction, DHA on its own, as opposed to fish oil, which contains DHA and EPA, might be utilized if somebody says they feel more tired or more brain fogged if they try fish oil or similar. DHA and EPA have different methods of absorption and metabolism, and EPA has actually been found to be higher than average in a number of neurological diseases relative to DHA. I personally take DHA on its own. Okay, we're going to kind of go into some of these a bit later. So I'm going to skip through this. Here we go. This is a pretty big deal in MECFS and a number of ongoing inflammatory states. The anemia of chronic illness, which is also sometimes called the anemia of chronic disease, the anemia of chronic inflammation, the anemia of infection, is an adaptive host strategy whereby macrophages, enterocytes, and probably other cell types too, sequester iron. So they basically suck up all the iron. And the reason that they do that is because iron is a really powerful metabolic mover. So that's great for us, the host, but it's also great for pathogens. If a pathogen is going to metabolize anything, it needs iron. So it's a very common strategy if you have ongoing inflammation or ongoing infection to soak up the iron and keep it from pathogens. Unfortunately, then your other cells can't use it because it's being hidden. So a lot of people, a lot of medical providers will give intravenous iron, but of course, then that causes all the infections to reactivate. People tend to have a very bad time. Um, I think lactoferrin is useful here. I should say that I'm not a doctor, but because lactoferrin has an iron core, it has a heme core specifically, but it's also very strongly antimicrobial and it has immunomodulatory effects. It tends to allow the body to absorb iron without providing iron for the pathogens to use. So I think especially if you see low iron signs, but with your ferritin normal or even maybe a little high, um, it might be worth looking into the anemia of chronic illness and treating accordingly. The other thing that might be relatively new is the coenzyme Q10 story. CoQ10 levels in people with ME are typically about half that of healthy controls. This is according to more than one study. And we've seen multiple studies where CoQ10 levels increase and symptoms decrease when CoQ10 is supplemented in people with MECFS. However, again, this is my personal opinion. I think we dose very low in ubiquinone. There have been multiple studies in other neurological diseases with doses that are many, many times higher. And the safety profile for ubiquinone is very, very good. It also does not linger in the body after cessation of administration. And also muscular tissue and nervous system tissue have trouble absorbing CoQ10, which may mean it may be part of why we need our dose higher. So yeah, last but not least, I would say dose with ubiquinone, not ubiquinol. We talked about fat soluble versus water soluble. A lot of doctors recommend ubiquinol because they're like, it's absorbed so fast because it's water soluble. But what did we also talk about? It's eliminated so fast because it's water soluble. We actually want something that is taken up slowly and eliminated slowly, in my, again, very personal opinion. So ubiquinone, I would consider to be more useful in this context. In order to string together all the facts I just told you, here are all the citations. It's a lot. Keeping an eye on the time. I want to make sure that we have time for questions, but it looks like we're doing pretty good so far. So, especially in severe ME, but in all ME, digestion is of primary importance. Digestion and metabolism. If you're not digesting and you're not metabolizing, it doesn't matter what medication you're taking. So this is often why we see that in severe ME, if you can actually dramatically improve the digestion, you can begin to repair a lot of other systems. I remember when I was in grad school, one of my professors who was in nursing talked about the medication to be delicate going out precisely the same way it had gone in. Obviously, if you're not digesting the medication, you're not making use of it. So I start with primary interventions because these are the ones that I think probably even healthy people could make use of all this advice. Digestive enzymes can be very useful. They are not, they're not actually medicine. They're proteins that help you break down fats, proteins, and sugars. Psyllium fiber is just an expansive fiber. As long as you drink it with plenty of water, it can be very helpful for slowed motility. Bitters, digestive bitters can be very helpful. Omit the ones that contain senna because it's a chemical laxative and you can become dependent on those. And then beta-ene hydrochloride, which is a B vitamin precursor, but the hydrochloride means it makes your stomach a little more acidic and you're going to be able to digest a little bit better. Provided that people with ME are able to sit upright during meals, they should. Stop eating earlier in the day, eat smaller meals more frequently, eat your meals with lots of water, preferably with electrolytes, so that you don't necessarily dilute your stomach acid as well. Again, we want to avoid swings in blood sugar. And we talked already about kind of chopping fruits and vegetables very small in order to be able to digest them. Of course, we want to avoid spikes in blood sugar, so it depends on your individual whether that's a good idea or not. But higher sugar foods could be used as a kind of rescue med if the blood pressure or the heart rate is really low, and or if the person is in PEM. Avoid anything alkalizing and utilize diet diaries to find out if you have any allergies or intolerances, I still do think intolerance tests, IgG intolerance tests, are useful, even though there's not a lot of peer-reviewed data backing my feeling on that. This is when things get a little tougher. There are dysmotility drugs. Pyridostigmine is one of them, but also mirtazapine, metchloropramide. These are things that you can talk to your doctor about. If allergies and intolerances are present, we want to kind of look at MCAS drugs like H1 and H2 blockers, cromolyn sodium, ketaphin, montelukast. Cromolyn sodium, I feel like, is underutilized. I feel like it's a good drug. Rifaximin, if SIBO is diagnosed, we talked about SIBO a little earlier. Rifaximin is kind of considered the standard for that. And thanks to Carolyn Christian for providing some communications on digestive issues and severe ME. I had to reach out for multiple personal interviews with people who had treated or dealt with folks who had severe ME, because there's so little literature out there that you just need to talk to people with personal experience if you want to have a conversation about these things. And this is the same thing about avoiding multiple different strategies at once. People have talked about elemental diet for gastroparesis. That is not something that I have had experience with. That's something that's been recommended to me. Well, that's interesting. We have a lovely little line down the presentation, at least from my point of view. So this is when it gets pretty serious. If you have somebody with severe ME and you need digestive help, you might have to go to a compounding pharmacy for medications to avoid allergies and intolerances. You might, in addition to trying the other MCAS drugs we mentioned, you might need an immunosuppressant like an anti-IgE therapy. And the strangest thing about MCAS is that you can take something that the person is having a response to, bring it far, far, far below the correct dosage, slowly creep up on it, and they won't have a response. I've seen multiple case studies that describe this in the literature. It's challenging to go out on a limb like that, but if the patient is suffering, that's what you have to do. And you'll see that I do have that cited. So if you have to take that to a doctor, there's evidence that that may end up being helpful. Gastroparesis, people don't realize slow digestion can lead to dehydration. And so some of the symptoms that present look like an orthostatic crisis. So hemodynamic instability, heart rate and blood pressure all over the place. Just administering saline can help with digestion. People don't realize. And if somebody actually does end up in the hospital with inability to digest, it's really important to call for a consultant with expertise in refeeding syndrome. So I did end up talking about IgG testing. I thought it must be somewhere. Use diet diaries as well. And I always find it really fascinating and horrifying that MCAS can be incited even just through getting too cold. But I suppose the same thing is true of PEM. So for orthostatic intolerance, we've got our usual meds, pyridostigmine, midodrine. Like I say, be very cautious with glucocorticoids. Vitex agnus castus is chaste tree, and it's very useful for a number of issues in MECFS. But part of the reason that it helps regulate blood pressure is that it regulates progesterone, and progesterone helps maintain fluid balance in women in particular, although I'd be curious to see if it has a similar effect in men as well. And of course, there are always the management strategies: compression socks, compression stockings, abdominal compression, and saline as well. Drinking fluids with electrolytes can be very useful, and a higher salt diet as well. Some people say not if your POTS is adrenergic, but mine is, and I still benefit from salty food when I'm feeling a little sick and dizzy. This might be one of the most original slides because I asked people what they did for sensory sensitivity. And these were their responses. So this is directly from kind of polling patients, along with some citations for the fact that high levels of serotonin or high serotonin reactivity can lead to sensory reactivity, and what might help modulate serotonin. Okay. So let's move on to strategies for how do you talk to your healthcare provider about what you have and how do you get what you need from them. It's important to recognize that providers don't have a lot of time, and the fact that we have now it should be more than doubling of this underserved patient population. Specialist providers are not in large enough numbers in order to get all of us all the care we need. And obviously, the disease is chronic complex. And that means that it's hard for people to understand. So, we want to put ourselves in the shoes of the provider and think, what is it that they need in order to deliver the care that we need? So we want to make sure info is digestible and avoid overwhelming them. This is probably one of the most common, I won't say mistakes because I think it's the right strategy for a provider who's really curious. But most providers just want the information that they need to treat you. And many patients will come in with 20 resources that they think are good. What you want to do is to collect resources that are short, sweet, and to the point, that mention the interventions that you think you want to try or would be useful, and that are from highly reputable, widely respected sources. So that doesn't mean respected by the patient community. That means respected by the clinical community or medical community. You may recognize that like a patient group is really good about vetting their information and they always provide good things, but your doctor doesn't know that. They want something from CDC, for example. You want to recognize and start looking for the meds that are general quality of life improvers in the disease and try to get those first. Again, a lot of the ones that I personally have seen people respond most positively to when they're talking about it is LDN and pyridostigmine, but that's by no means an exhaustive list. And then address the single symptom that has the greatest impact on you with your doctor. Also, it's important to understand the difference between the acute and the chronic approach. Holistic providers might be better at addressing digestive and metabolic issues, especially in severe presentation, whereas your average GP wants to give you a single medication likely and send you on your way. But if it turns out that your healthcare provider really wants to partner with you, then here are some ways that you might be able to get more time to talk to them. You can ask if you're able to book 2 appointments back to back, and the provider might be able to bill as 2 separate appointments or to bill for extra time. You can book appointments for once a month if you're doing very badly and you're desperately in need of care, and then when we're stable, maybe once a season, and then hopefully eventually once or twice a year. Some insurers have very specific time limits for regular appointments, but if you call your first consult your annual consult, you can get the full hour. And I also see some people chasing after the latest medication, but flash in the pan interventions are probably not a good use of your time, energy, and money. You want to have probably a number of think of each management strategy and each medication as a block in your total care plan that's going to actually build something useful for you rather than one medication as a silver bullet. This is a question that a lot of people have. What do I do if I have a provider that is not an ally? And I know that this is a little bit of a hard pill to swallow, pun totally intended. but you should try, if you are at all able, to find another provider. They're unlikely to be convinced that they should reconceptualize their understanding of a disease unless they hear that from somebody that's in their own social group. We see this about changing your mind in a lot of other arenas. But passing on one really good resource before you go or as you leave, I think is a good practice, because our goal is kind of to hopefully educate for the next person who walks through their door. Maybe they'll feel a little differently. But spending a great deal of time attempting to gain reasonable care when you've encountered an actively hostile or disinterested person can deplete your financial and psychological resources. You don't want to leave sicker than you came in. All right, looks like we're keeping this about on schedule. So last but not least, if you would like to make a donation because of what you've heard today, if this information has been valuable to you, I hope you will consider doing so. Because I do give talks outside of MEAction, but this talk is on MEAction time because this is my usual working hours. So we would certainly appreciate the support. I think that this is a harder time for nonprofits in general than ever before. And so I encourage you to support all the nonprofits that have helped you. So things that I would recommend that MEAction has had a hand in producing: the pacing guides that we discussed before, including the version for your clinician, the Mayo Clinic Proceedings article that describes the disease quickly, where I'm a co-author. It's less than 5 pages. It has 2 diagrams that you can get a lot of information from looking at, and it has a CME that's associated with it, so you can use it to educate your doctor as well. And again, it's that very well-respected source that matters. We also created Anki flashcards for medical students, and I created these with Erin Lee from MEAction Georgia. This is now recommended by the CDC, which gives them, again, that seal of approval by somebody that a doctor is going to trust. So if you have friends in medical school, please send them to those and share them widely. And you can also go through the questions yourself if you just want to learn more about IACCs in general. I would say that the questions are MECFS focused, but we include a lot about the other IACCs as well that you may have as a comorbidity. And finally, the Ask Jan website for MECFS has school and workplace accommodations, and my colleague Ben Suborger worked on that with them. And so that is another very highly reputable source for accommodations if that's something that you want to talk to your doctor or your workplace or your school system about. And this is if you would like to access the concise clinical review to pass on to your provider. You can scan this. If your phone isn't working or what have you, search my name and Mayo Clinic Proceedings and you'll find it very quickly. And that's it. I see we have 8 questions, so I think I'm going to go ahead and scooch through them. I'm going to take a drink of something first. Okay. Director Seltzer, not doctor. Okay, below normal lymphocytes and immune testing. I've tried many things to boost this with no luck. Is this a pattern you see? And what would be the approach to trying to raise lymphocytes? That is a challenging one. We see multiple different signs of immune deficiency ranging from minor to severe in patients with these diseases. Either decreased natural killer cells in number or decreased function in terms of perforin and granzyme B production. We see higher numbers of naive B and T cells, which means, well, it has a lot of implications, but it's seen in immunocompromise. And we see CD4 and CD8 ratios of T cells off. So there are a bunch of immune dysfunction that we see here. Below normal lymphocytes is not necessarily something that I have enough data to say is associated with this disease. In terms of raising lymphocytes, because it's not typically in this disease, I'm unsure about what would cause them to elevate. I'm sorry to say that I don't have enough information about that. but you can at least comfort yourself that I did not make something up for you, which is what many other people do. We will have to ask MECFS San Diego if we can have the presentation, but I assume that that's going to be posted. I'm not sure if the slides will be available for download themselves. I'm always reluctant to do that in terms of putting stuff out there that's not been peer reviewed. So frustrating, a lot of these doctors aren't looking up proper dosing without being prompted. That is definitely true, but the issue is that they're not used to dosing as low as they need to for us in particular. So they're looking at like the lowest dose being 60 milligrams, but they know they need to start lower than that and go slow. So then what they do is they still dose at the same frequency as you would for 60 milligrams slow release, even though the dose that low is not a slow release. So it ends up getting complicated. I will say what I do personally, as long as you guys understand that this is just my personal opinion and I'm not advising you to do this as a clinician. I get the 60 milligram pills. They have an indentation that allows you to easily split them into quarters, and I take 1/4 4 times a day. So essentially, the 60 milligrams disappears over the course of 24 hours. But I take it about every 5 hours because for me, that's how fast I metabolize the med. And it took me fussing around with it. I have a friend who was given that dose and told to take it once a day. Experienced doses of high symptoms of high acetylcholine and then symptoms of deficient acetylcholine every day that they were doing that, as it was too high and then wore off and then too high and then wore off. So I think dosing can be really challenging in this population because of the slow metabolism and the need for super low doses. I recently had my gallbladder taken out. Is there any connection? Possibly in terms of digestion being affected, but I don't think that there is an association with onset beyond the fact that surgery can sometimes precipitate onset because it's an immunological challenge. Do I have recommendations for dosing with lactoferrin? Yes, I do. Again, this is very personal. This is my own personal opinion, not medical advice. Lactoferrin is an immune activator. That is its job. So you have to be aware of that when you're starting it. And I started taking it when I was in my very high inflammatory phase. So I took a little bit and put it on my finger, put it on my tongue, saw how I reacted, waited. Eventually, took it up to one 250 milligram pill that I took before bed to sleep through any inflammatory symptoms. Over a long period of time, I'm now taking two 250 milligram doses twice a day, once in the morning, once at about 2 p.m. when I take my afternoon meds. And that's what's been helpful for me. I mentioned it as an immunological help, but the thing that I notice is that without lactoferrin, you could just set me somewhere quiet and I would be unconscious in 5 minutes. With lactoferrin, my fatigue is much more manageable. And I would say sleepiness, that aspect of just being able to sleep anywhere, started to go away when I began to take lactoferrin at a reasonable dose. And I understand that lactoferrin and CoQ10 are pricey. Someone says it's expensive up here, and I'm like, yeah, it's expensive everywhere. I spend more money personally on CoQ10 than any other medication, but if I didn't, I would not be functional. So it's just one of my desert island meds, and I accept the hit, you know. Low dose aspirin, but a doctor said it is not possible. I'm not sure what that means. Aspirin's a great general anti-inflammatory as long as you don't have reflux or anything that would prohibit you from taking it. I think it's great. There's nothing wrong with a generalized anti-inflammatory. Just because aspirin is cheap and easy doesn't mean it's not good. Especially if I begin to get inflammation at the back of the skull, which is an early PEM sign for me. A little bit of aspirin and then often a little bit of feverfew, which is a good serotonin blocker, which is a migraine med for me because of that. And it will definitely cut the symptoms and it can possibly even mitigate the PEM. Ozone therapy. What I would say about ozone therapy is that there's not enough evidence to support it. Which doesn't mean that it doesn't work. It just means we don't have evidence that it does work. Um, okay, so does anybody have any other questions? Because we have 2 more minutes. We've reached the end of the list. Very low iron and ferritin. You react to lactoferrin. Yeah, like I said, I did too. But if so, maybe consider treating it like you do another MCAS med. Put super subclinical doses and slowly work up over time. I personally have used Jarrow, JRROW brand. IV iron infusions, how to prepare for those. Once again, I wouldn't in this disease. Because I'm too troubled with the idea that it would cause reactivation of latent infection. And I have certainly heard it's so hard when what you're dealing with is patient reported information. So you guys just have to understand that when I say this, that's what I'm referring to. I have never heard a positive story about iron infusion in MECFS. I have heard multiple negative outcome stories about iron infusion in MECFS. I understand if your iron is very low, that might be what you refer to, but I was talking to a hematologist a week ago, and she explicitly said never give iron infusion in anemia of chronic illness. So in that case, it's not just me. Ooh, we're getting lots of questions. All right. A little bit about malnutrition. Tied to MCAS, an extremely limited diet. Is a feeding tube still potentially appropriate? Yeah. Thank you for the trigger warning. My mom actually experienced pretty severe um malnutrition when she was first sick. And it wasn't because she was too weak to eat or digest, it was because she had too many new food allergies and intolerances. She found safe foods that she could eat by eliminating nearly everything. And she's back up to a healthy BMI, although at the very, very low end of a healthy BMI. So I think that what you need is a nutritionist who understands multiple allergies and intolerances and can help them find a handful of safe foods. I think the worst issue for someone with ME who's limited that way is that food stops being a pleasure. Um, they know that they can eat these 7 things, but how many different variations can you do on these 7 things? So you risk losing their appetite as well, and that it becomes a task. And I do think that it is that way for a lot of people. But it's a task that has to be done. If there are 3 things that they know that they could eat, they have to eat those 3 things in order to get nutrition. And they probably do have to have multivitamins and electrolytes in order to ensure that they're getting the vitamins and minerals that they need to do decently too. Because when you limit the numbers and types of foods that you can eat, you limit the variation in the different vitamins and micronutrients that you're actually absorbing. So you need a good multi. Yes, migraines are part of MECFS. Brand recommendations for CoQ10, I use Solgar. Solgar Mega Zorb. Okay. Can neutropenia and leukopenia with higher natural killer cells be connected to MCAS or infection? Infection is common. Like if you see high monocytes or yeah, that often indicates there's some kind of active inflammatory and often infectious process going on. Starting IVIG. Make sure you're well hydrated first. How long do you space medications? So I suppose if I'm understanding that correctly, it depends on whether it's fat soluble or water soluble. And I will usually go on and off the same medication multiple times before I will add a new medication. Can chronic very low vitamin D be connected? Yes. Yes, it is. Very low vitamin D is associated with this disease, and it's associated with any disease of ongoing inflammation. Unfortunately, I think we're out of time, guys. I do have a 3 p.m. Once again, I'm going to go ahead and put in the donate button. If you've benefited from this, please feel free to donate to MEAction.net. And again, all of your nonprofits need your help. If you have, appreciated what your nonprofits have done for you this year, it is a challenging time. So I hope that you will if you're able. And if you're not able right now, that's okay, because all of us have been through hard times, so we understand. Thank you so much for having me. This has been wonderful. I hope you enjoyed it, and I hope you will you'll follow me on Blue Sky, and so that you can find out where I'm speaking next. Thanks a lot, everybody. I have a 3 o'clock I'm late for, so I'm gonna have to go.
Bye. Thank you, Jamie.
Thanks.
All right, folks, thank you for coming. And like I say, I'll trim down the presentation and put it up on our YouTube channel as quickly as I can. Doesn't sound like we'll be able to get the slides individually, but hopefully you'll be able to pull the information out of the presentation that you're interested in. Once again, thank you for coming. And we'll see you next time. Bye-bye.